but we have our duties. And I'd like to welcome you to this press conference being on the studies that will be presented in the hotline session 1, Thrombosis. We'll have 5 speakers who will talk for 5 minutes and not more. And then after each presentation, we'll have a question and answer session of another 5 minutes. We also have in the room 3 of the ESC spokespersons, Freek Verheugd, Kurt Huber and Michel Bertrand, which will be helpful in the discussion, so you can also ask questions.
Would you mind standing so everybody knows who you are? I'm sure they know already.
There they are. He has a mic already, so I can answer all your questions. So I'd like to start with the first presentation, which will be by Professor Harry Bühler from Amsterdam.
No, we're going with number 2.
Oh, we're going with number 2, so we have the schedule.
Just loading the slides.
So the second one is Professor Ole FROBERT from Orebro, if my pronunciation is correct, from Sweden.
It's impressive.
Thank you. And he'll talk about the TASTE study, and that stands for Thrombus aspiration during ST segment elevation myocardial infarction, so patients coming in with a myocardial infarction, a multicenter prospective registry-based randomized clinical trial.
Good morning, ladies and gentlemen of the press. Imagine that you had a heart attack. You've never tried this before. For the first time in your life, you have severe pain in your chest. Your spouse, your husband, your wife calls the ambulance. Already in the ambulance, they put on electrodes. Perhaps they put in a line. They give you some pills, and you still have the chest pain, and you rushed to the hospital. In the hospital, they will continue to treat you. Everything is done very well choreographed. They will give you more medicine, something in your line, maybe an injection in your thigh. They will inform you about a number of things, and then they will rush you down a corridor for something they call the cardiac catheterization laboratory. And the purpose is they want to remove the clot sitting in one of your arteries in the heart in order to treat you and relieve your pain. You would like to believe that all of these nicely choreographed steps have been investigated in detail and that we have evidence for what we do. Unfortunately, we don't. A number of these steps have never been investigated. And why not? Because it's very, very expensive to do a randomized clinical trial. There's no revenue potential in a lot of the treatments that we do. No patents can be taken out. And in comes the TASTE trial. In TASTE, we study a very important step in this process. I will come back to that. And we do it in a completely new way, which is more efficient, more patient-friendly, faster, and much cheaper than in a normal, conventional randomized trial design. So the trial hypothesis of the TASTE trial is that, or the postulation we wanted to address is that the thrombus that causes a heart attack before balloon dilatation and standing, or removing the thrombus that causes a heart attack before balloon dilatation and standing improves survival. Here's my declaration of interest. In total, 29 Swedish, 1 Danish, and 1 Icelandic hospital took part in the TASTE trial. It was a multicenter prospective randomized clinical trial, open label, 7,244 patients who had a diagnosis of ST elevation myocardial infarction, or STEMI. We used this for the first time novel registry-based randomized clinical trial concept, meaning that we used national heart registries as platforms for randomization, case reports, and follow-up. This means that no patients were lost to follow-up. We had a powerful tool to capture data with a high degree of fidelity, and the concept is very inexpensive compared to the cost associated with conventional randomized trials. Half of the patients were assigned to balloon treatment only, also known as percutaneous coronary intervention, and the other half had their blood clot aspirated before the PCI. The TASTE trial is by far the largest clinical trial ever on thrombus aspiration or removal of blood clot, and we included more patients in TASTE than in all major previous trials on this subject combined. We studied this many patients in order to be able to address whether the technique is life-saving or it reduces other so-called hard clinical endpoints, such as a new myocardial infarction or stroke. Questions only a very large clinical trial like this can address. Here's the main primary result. The mortality rate at 30 days was not statistically different between the two groups. 2.8% of patients had died in the thrombus aspiration group and 3% had died in the PCI-only group. The almost identical numbers do not allow us to conclude that one approach is better than the other. Similarly, there was no difference between the two groups for secondary endpoints, including risk of a new heart attack, stroke, and complications related to the treatment. And even high-risk groups, such as smokers, patients with diabetes, or patients with large clots, had similar results with either approach. So our results do not support a role for clot aspiration as a routine future treatment. The current European Society of Cardiology guideline recommendation is that clot aspiration should be considered. The results from TASTE will likely have an immediate impact on the guidelines and on clinical practice on treatment of patients with a heart attack. The study's unique, registry-based, randomized clinical trial concept is a new, efficient, and inexpensive way to assess treatments in large patient populations. The costs are reduced to 1% or less of a conventional randomized trial and enables the testing of treatments that have no revenue potential. It's our hope that the concept can help to reverse the decline in the number of new clinical trials being started within the entire area of medicine. For a detailed description of the TASTE study, please refer to our paper, the editorial, and the perspectives article in the New England Journal of Medicine, available online now. Thank you very much for your attention.
Well, fantastic study. Are there any questions to all?
Fredrik, I think you were first.
No.
Oh, you were holding it up. Yeah, the lady in the front.
Could you give more background about how the registry concept actually works?
It works in the way that we already do all this work in most Scandinavian countries. We have registries for almost every health parameter in the health system. So we already put in all the information about the patients. So it's very straightforward to think, why not use the information we already entered instead of doing it once more in a clinical trial. So the idea is simply using what we have and then building on that and randomizing from that.
So you randomise after they've entered. You randomise after they've entered the registry.
Yeah, the registries goes back many years, but they have been web-based like the last 10 years, and then this opens for this possibility.
It's retrospective.
Yeah, well, if you look back in it, but we fill out all information while we see the patient. So that is.
There's another question at the back.
I'd like to hear from some of the other investigators here. Many of you have a lot of experience with clinical trials. If you think that this model will be adopted more widely and how that will be done, what the obstacles are, because it strikes me that this is something really, we've never seen before and quite important.
If I can begin, Larry, I think this is a really exciting and innovative approach. I entirely agree with what Ole said, that in a number of our countries we have large registry programs, and then to consent people within the registry and derive a trial where the outcomes are automatically collected in the system makes it incredibly cost effective. And indeed, we used and adopted this when we did the 5-year outcomes with Gabriel Steg in our combined GRACE program. Kurt.
If you break the data down to the different devices that have been used to retract thrombi, and also to the experience of the investigators, is this possible? And would you see then differences?
In the TASTE trial, there were 3 different devices used. And we did a post hoc analysis if there was any difference between the outcome according to device, and there was no difference at all. Okay. P-value of 0.3. And your second question, sorry?
The experience of the investigator.
Yeah, in Sweden, the angioplasty registry, which is the main basis for this study, we do reports every year, and we also do statistics. Are some centers only on center level? Are some centers worse than others? And there are no statistical difference, and nothing in the data from the TASTE indicates that this should be a
Ole, I think you should be congratulated on the scale and the size of the study. I have one key question. You present the 30-day data. Clearly, the impact may be much longer term, and presumably you're going to be analyzing this later.
Yes, of course, and thank you for giving us this opportunity to present once more. We must see how it looks after 1 year, of course.
Yes.
Yeah. Right now, there's no.
Because if you did the reperfusion studies at 30 days,
yeah,
they wouldn't have looked beneficial.
No.
Okay.
There's another question over there.
Yeah.
Hi, Lynn Peterson with Trends in Medicine. So could you tell us what 3 devices were used? And in the journal article, it says that this was funded by the some Swedish association. But Medtronic, in their release, said that they partially funded it. So was this mostly funded by industry or not?
It was mostly funded by regulatory bodies in Sweden, but we also had unrestricted grants from Terumo, Medtronic, and Vascular Solutions, the 3 companies behind the 3 devices we used.
Over there's another.
Okay, a last question, please.
You went quickly by the actual negative results. There must have been some reason why you suspected you might get a positive result, and do you have any explanation as to why there was no benefit?
It's very difficult because within this area only very small trials have been conducted this far, and some have shown positive results, some have not. So it's really a lot of noise in this area. I think we couldn't say anything before we did the real trial. Yes, okay. And a rather recent study, the INFUSE-MI, very well designed study, Greg Stone and associates didn't find anything either. So I think maybe there's not much to find there with the thrombus aspiration.
So can you speculate why doesn't it work? I mean, intuitively, it's the way to treat a myocardial infarction, to take out the clot and not let it embolize to the distal vessels. Why doesn't it work?
The idea is very good, and among our secondary endpoints there was a trend, but it was not statistically significant for fewer myocardial infarctions and fewer stent thrombosis.
Okay.
But the numbers were very low.
All right.
Okay.
But we do need to see the long-term data.
I promise.
Okay, thank you. So please remember that you have chance for one-to-one discussions at the end. So we must keep to time, and I'm delighted